Uh, Thank you, sir. This is a rather longish topic, so please allow me if I overshoot a little on time. We have ample
No,
time.
you have a luxury of extended time
Thank
because
you so much.
two speakers are not there.
Yes. So the first important thing to understand in this particular area is the difference between a stunned myocardium and a hibernating myocardium. So this cartoon shows that whenever there is a decreased perfusion in a particular area, there is also a reduction in function, the top of it. But when the ischemia is relieved and the perfusion is restored, the function of the myocardium continues to be low, despite the perfusion having been restored. And this entity, when you have a restored perfusion, but you continue to have a myocardial dysfunction, this is known as myocardial stunning. On the other hand, if you have a reduced perfusion and you continue to have reduced perfusion, the, the function of the ventricle continues to be hypofunctional. And this, myocardial dysfunction, or you can say the hypocontractility of myocardium, in the presence of in the presence of a continued hypoperfusion, is called as hibernation, and that is going to be the major topic of discussion in my talk. So what is a viable myocardium? A viable myocardium is generally referred to as an alive myocardium, independent of its contractile status. So it is alive, although it is hypofunctional. This term is actually derived from hibernation, as we all know, is derived from amphibians. Whenever the winters come, the amphibians go deep into the water and they reduce their functioning to the extent that they are alive, but they are not moving around. It is also important to remember that all ischemic hearts, whenever we do any reversibility testing, we do a treadmill, we do a dobutamine stress echo, or we do a stress thallium test or a stress MPI test, we are actually detecting ischemia. So it is important to remember that all ischemic hearts are viable, but the contrary is not true. All viable segments are not ischemic. They may not show ischemia. It is also important to remember that in order to judge whether the myocardium is alive or not, it has to have some degree of preservation of wall thickness. It has to have a contractile reserve, as we understand, to have cellular membrane integrity and an active metabolism. The substrate changes, but the metabolism has to continue. And this metabolism needs that there is some amount of, perfusion by the blood. It can be an antegrade blood flow, and many a times we find that there is 100% block, but the artery is getting perfused through ipsilateral or contralateral collaterals. So the existence of blood flow is also very important. Now, all this is theoretical. The main thing is, the main importance of viability is whether the functioning of heart is going to improve once the flow is normalized or not, once the flow is normalized. So as I said, the tests for viability take into account all these features that are highlighted in this particular slide. That is, there has to be some minimum amount of wall thickness of the myocardium. The myocardium, when stimulated, should be able to contract more than it is doing at the baseline, or what we call as contractile reserve. It has to have cellular integrity. You cannot have destroyed cell wall or the integrity of the cell destroyed and have a viable myocardium. And it has to continue to have metabolism The substrate, however, changes. We need to understand that the normal substrate for a normal heart is free fatty acids. And when there is a continued hypoperfusion or low flow to the area, the substrate changes to glucose because this is a more energy efficient pathway in those given scenarios. And so the metabolism has to change from free fatty acids to glucose. And as I said, the perfusion is a must. It is not that you can have no perfusion at all and have a viable myocardium. So based on that, this also shows the four major ways in which myocardial viability is detected. It can be detected. There are some non-invasive and other markers also. But by and large, we either use echocardiography, we use positron emission tomography, or the PET studies, as we call them. We also have thallium studies and technetium-based, perfusion studies. And in the center, as you see, is the CMR, or the cardiac magnetic resonance imaging. This is in the center because currently it is believed that the best resolution up to the tune of about 1 to 2 millimeter is actually given by magnetic resonance imaging. So this is also believed to be one important method of diagnosing a viable myocardium. The concept of viable myocardium is not very new. It is about 20 to 20 years old approximately. And this is one of the seminal editorials by a person who did a lot of work in this, Shahabuddin Rahimtullah. He actually showed in one patient who had an LAD disease and the ventricle that was dilated, which is shown on the left of the screen. After the CABG was done, there was a great improvement in the ejection fraction from 37% to 76%. And this was largely contributed to by a reduction in the left ventricular end systolic volume. So if somebody asks me what is the single most parameter that changes, it is actually the left ventricular systolic parameters. Now, this is based on the fact that he also observed that if you have a normal heart and you develop occlusion, in the acute stage itself, when you revascularize, the functioning normalizes. If the blockage continues over a period of time, you have remodeling. And if you revascularize the heart early in the remodeling, it normalizes. If you revascularize it at a relatively late time, there is a reversal of this remodeling, but it is to a lesser extent. And if you have it in an absolutely dilated ventricle, and I'll come to this concept later again, there is the benefit is actually questionable. So when do you use viability testing? Not in very young patients, not in people who have angina, not in people who have a normal left ventricular function, and not in people who have ischemia on the routine testing like treadmill or dobutamine stress echo. But it is more useful in people with left ventricular dysfunction, in the people who are relatively older, who don't have any angina that is present, and on their angiography you find a chronic total occlusion. And the purposes of the viability imaging are basically to plan the revascularization strategy, to risk stratify the patients, because those who don't have a viable area, they fare much worse. Their prognosis is much worse as compared to those in whom there are viable areas. And also to plan the revascularization strategies, as Dr. Pandey just alluded to. And there are some situations like a low flow state with aortic stenosis, for example. So these are the situations in which viability imaging is used. Now, the indicators of viability, well, if a person has angina, you really don't have to do, it should be a true angina. There, that is the strongest marker of the fact that even if the ventricle is dilated, even if the ejection fraction is low, and there is hypoperfusion, if the patient is having angina, that is the strongest predictor of the fact that the myocardium is viable. There are other markers, easier markers, such as lack of Q waves in the ECG. Many a times we get a patient who has a proximal LAD disease, but there are no Q waves on the ECG. Likewise, there are studies to show that persistent T inversion after a myocardial infarction is another marker of viability. Further, if many a times when we send our patients for a MPI scan, the nuclear cardiologist sends the patient back saying that though there is hypoperfusion, because there is a preserved wall thickening, the ventricle is very much viable. From our knowledge of echocardiography, we know that a myocardial infarction on echo or a scar is defined as, number one, failure to thicken, or systolic thinning, or failure to thicken by more than 10%. Also important is the presence of a contractile reserve. Many a times we find left ventricular angiography is seldom done these days, but in the good old times, when I did my DM, left ventricular angiography was a part and parcel of doing the cardiac catheterization, even if it was coronary angiography. So one noted that if a hypocontractile area increased in contraction after production of an extrasystole, the post-extrasystolic accentuation was enough to tell you that this patient has a contractile reserve. Although now in the modern times, we have more modern methods. So on the thallium scans, if we have radionuclide uptake, which increases by more than 50%, if we have seen any nuclear scan on the right side of it, there is a bar chart which shows areas which are absolutely dark to those which are bright orange. So that is the sliding scale on which the perfusion changes. And if there is a greater than 50% increase in the radionuclide uptake, that again is a marker of viability. Likewise, as we shall see, if there is a mismatch of perfusion and glucose uptake on PET scan, that is again a very strong marker of viability. And if you have on dobutamine stress echo, particularly, if you have a new inducible increase in the contraction, that is again a predictor of myocardial viability, because it tells you that this patient has contractile reserve. And if there is no or minimal late gadolinium enhancement on the cardiac magnetic resonance imaging, then again it is an indicator of viability. So this slide actually shows that what is the sensitivity, specificity, a positive predictive value of all the non-invasive tests of viability. And as we find, if you consider both sensitivity, specificity, positive predictive and negative predictive value, the gold standard is at the present time is FDG PET, although a tough competition is being given by the cardiac magnetic resonance imaging. So these are the various modalities on the left side. So you have nuclear imaging studies, which actually use perfusion, cell membrane integrity, and presence of intact mitochondria on, to judge whether the area is viable or not. And the PET scans actually use the change in metabolism as the indicator of viability. echocardiography and dobutamine MRI, they use contractile reserve, and the plain MRI uses the presence of scar tissue as a predictor for viability. Now, as far as echocardiography is concerned, as I said, we have known that if the ventricular wall is excessively thinned out, the presence of a ventricular wall thickness of less than 6 millimeter is actually a very clear indicator that this is likely to be non-viable myocardium. And when we do dobutamine stress echo, these are the various types of responses that we can have. And so what we find is that if a patient has a biphasic response, which means that when you start the patient on low-dose dobutamine stress echocardiography, the contractility improves, and later on at high dose or peak of the dobutamine stress echo, if the contraction decreases again, this is the strongest predictor of viability. And of course, you have different types of responses on dobutamine stress echo. Now, as far as the nuclear scintigraphy is concerned, as I said, the radionucleases, they need to get into the cell. And for that, you need the integrity of the cell wall. As far as the nuclear scans are concerned, most people do not use thallium scan any longer. The good old thallium used to behave as potassium. And we know that potassium is an intracellular ion. And so thallium would go into the cell, and that it can do only well when the cellular integrity is preserved and there is some degree of metabolism occurring. So based on the thallium scans, we could predict more reliably whether there is myocardial viability or not. And I said, if there is a 50% increase in the tracer activity or more than 50%, then this is the most important criteria to be used in SPECT imaging. So on the top are the agents which are used for SPECT imaging, which is mainly thallium or sestamine. And for PET scan, we have perfusion imaging, for which people use ammonia or rubidium. And we have the metabolic imaging, for which we use fluorinated deoxyglucose. Now, the thallium scans divide the segments of the myocardium in pretty much the same way as we do on echocardiography. And two types of things are important. What is the defect severity? As I said, it should be a more than 50% change. And what is the defect size? Because those two factors determine whether the function is going to improve or not. So this is a typical nuclear scan picture that we see. The first one is normal, which is showing orange color in the entire thickness of the myocardium, both at stress and at rest. Sometimes such defects may be present both at both at rest and at stress. And these are large areas, non-specified vascular territory. These are basically attenuation artifacts. The attenuation artifacts are more importantly present in the diaphragmatic surface and the inferior wall of the myocardium. If the defect is fixed, that means at stress also there is no perfusion, and at rest also there is no reperfusion in that area. This is suggestive of a scar. And the most important for us is on the extreme right. If we see towards the apex, there is a blue area on stress, which fills up with the orange perfusion at rest. And this shows that there is ischemia, and this is going to be a viable myocardium. As far as the PET scans are concerned, as I said, this consists of two imagings. One is the perfusion, which means the blood is going there or not. And the other is metabolism imaging. And as I said, in cases of chronic hypernation, the substrate changes from free fatty acid to glucose. And so this is a typical PET scan at the bottom. And it has been seen that almost 1 in 4 segments, which are actually classified as non-viable on a stress thallium scan or a stress MPI scan, are actually determined to be viable on a PET scan. This is this is a slide which I've taken from one of my presentations for the CSI. I was asked to show a case where nuclear imaging had been done. And this was a 45 years old male who had an anterior wall MI. And this guy drove his car for 13 hours from the border of Chhattisgarh to all the way to Vijayawada in Andhra Pradesh. And his angiography was done. The angiographer found that LAD was 100% blocked. And however, he was one of those kind ones. He did not blindly go ahead and open it up at that time. He said that you should come later when we will do some tests. The patient landed up in Delhi. He was related to one of my colleagues. And so when he came to us, I got a FDG PET scan done. And as you see in the first picture on the left-hand side of the screen, there is a large blue area, which is the perfusion scan. So that is the technetium perfusion scan. The large blue area suggests that there is no or very little blood going in that area. And the middle one is the FDG or the perfusion scan, which shows that there is a good amount of uptake of glucose by the same blue area, which is showing on the perfusion scan, which means that the substrate of this particular area has changed from free fatty acid to glucose. And that is why this area is viable. And when you subtract the two images, on the extreme right, you see an orange area, which is the area of viability. And so I went ahead, I did the coronary angioplasty of this patient. And after 4 to 5 months, his ejection fraction had improved from 30% to 47%. And his left ventricular remodeling also occurred. There was almost a 5 millimeters decrease in the left ventricular systolic diameter. So if we try to know the pros and cons of all these tests, they are highlighted here. The SPECT is supposed to be more sensitive than dobutamine stress echo. We are all aware of limitations of dobutamine stress echo. You may have window problem and you may have a host of other problems. However, it is an all or none phenomenon. It doesn't have a great grading between the different types of viabilities. Dobutamine stress echo can use both the thickness, because we do a resting echo. So it can use both the predictors of thickness as well as contractile reserve. Cardiac magnetic resonance imaging uses the wall thickness as the most important criteria. And the PET scan, as I said, uses the viability. As far as the magnetic resonance imaging is concerned, again, the cutoff here, because it is a more sensitive parameter, is not 6 millimeters, it is 5.5 millimeters. And again, this is being used in many areas, as we see here. So you can have scar present in typically in 1 to 25% of the cases. On the second part of the cartoon, it can be 25 to 50%, or it can be more than 50 to 75%, or more than 75%. So if it is more than 75%, the scarred area, then it is clearly sure that this is going to be a non-viable area. If it is less than 50%, we are pretty much sure that this is going to be viable. And if it is between 50 to 75%, we do contractile reserve testing and then we are able to predict the viability. Now, the most often discussed trial for kicking viability, I would say, is the Stitch trial. Now, in the Stitch trial also, in the Stitch trial, what they had done is taken patients with left ventricular dysfunction, subjected them to medical therapy or coronary artery bypass grafting. In a percentage of people, about 40% of them, they actually did viability studies. And what they found was that whether you had a viable myocardium or not, there was no great difference in the results of doing CABG versus giving medical therapy. However, if you considered the viable segments and non-viable segments, there is a increase in the ejection fraction in those patients who have viable areas. However, again, as I said, the main point in the Stitch trial was that whether you did viability testing or not, this results of the CABG were not going to determine the ultimate outcome. However, there were many criticisms of this because the Stitch trial did not use MRI or PET. They used, SPECT or dobutamine stress imaging, which we all know are not the gold standards. Almost 40% of these patients were asymptomatic. The patients were never assessed for presence of ischemia, so it is quite possible that many patients had ischemia, and the LV volumes were not reported. However, this study did show, as I said, that if you have a viable area, your ejection fraction improves over a period of time. And there are subsequent studies which have shown that if you have a contractile reserve present, then that predicts the viability even better. This is a slightly older paper of 3,100 patients, which clearly showed that revascularizing, if we look on the top graph, if you revascularized the viable areas, then there was almost 80% decrease in the death rates. And it did not matter. It was statistically insignificant if you had medical treatment in these patients, which is given at the bottom. Now, further, it has been seen that if you consider viable segments, then the predicted death rates actually improve a lot. And on the right side are given the scatter bars, which shows that between the different modalities, what is the scatter? What are the 95% confidence intervals? So what we find is that for thallium and TSC, there is a very wide scatter. We can see the vertical bars are very big. But for FDG, the vertical bar is very small, which means that the results are more consistent and more accurate. So that continues to be the method of choice. There is also another paper which has looked whether the area of hibernating myocardium is important or not. And there was a PAR 2 trial of which this sub-analysis has been published. It has been seen that, if the viable area is more than 7%, then the primary outcome, which is a composite of cardiovascular death, MI, or heart failure, is less. And the number of patients surviving is also more. But there are 0 deaths in this. So I'll just be a very few minutes. So the 2021 AHA-ACC guidelines for coronary artery revascularization states, it remains unclear whether viability studies should be used to inform clinical practice. And if they are used, it remains unclear which should be used. There is a paper published in Journal of Thoracic and Cardiovascular Surgery, which tells you that it is not just the amount of dysfunctional but viable myocardium, but also the left ventricular volume, which is important. So I've tried to draw this in this chart. The first one shows a normal sized heart. The heart then dilates and we have a mild to moderately dilated heart. Here, the viability is important. But if you have an extremely dilated heart, as it is given in the bottom, then the neurohumeral systems have already overtaken the benefit of viability. Whether you revascularize them or you don't revascularize them, you're not going to get benefit. So volume is also very important. Now, the topic was actually the algorithms. So this is the most simple algorithm. If you have coronary artery disease and the patient has angina, he doesn't fall into this viability testing. If he has dominantly dyspnea, you check for left ventricular function. If the left ventricular function is normal, even this person does not need any viability testing. If it is low ejection fraction, then you do the viability testing by using myocardial perfusion scans or PET or dobutamine stress echo or MRI. And at the bottom, it is given clearly that if your patient has hibernating myocardium or ischemic myocardium, that is the patient who's likely to benefit from revascularization. This is a more simplified, but in terms of acute MI, if you have a negative ischemia test, suppose you have not been able to revascularize the patient in the 36 or 48 hours window, which is a class 2A recommendation of the ESC, then you do that and the ischemia test is negative. Go ahead and do the tests of viability. And if the myocardium is viable, then you consider revascularization, as I showed you in my case. So these are the last two slides. So the algorithm, which is given by the AHA scientific statement in 2020 on the imaging for myocardial viability. If your patient is suitable for revascularization, he goes to the second step. Then you assess whether there is presence of ischemia or not. If there is no ischemia, look at the extent of scar. If the scar is more than 50%, but less than 75%, you look at the contractile reserve. If the contractile reserve is present, then you revascularize the patient. If the contractile reserve is not present, then you leave the patient alone. And this is in subacute left ventricular dysfunction. If the patient is not suitable for revascularization, anyway, he's out. If he is suitable for revascularization, does he have any regional dysfunction? If he has regional dysfunction, test for ischemia. And if that is not present, test for metabolism or contractile reserve. And these are the patients who will benefit from revascularization. I thank you for your kind attention. A rather long talk, but